So, good evening, everybody. Just let me know in the you know chat if you can see me live. Just let me know if you can see me live on the chat. So, yeah. So there is a live chat. If you're seeing me on YouTube, you can just mark your attendance, put in your name. So let me talk about this session. This session is basically on high topics. So we will be taking NEET PG or I9 CT FMG high topics. So all these PG entrance examination will have some high topic, and a lot of questions directly indirectly get repeated from these topics. And I've seen students that just because they are kind of overwhelmed by the huge amount of syllabus, they are not able to even follow these high topics, and this is the reason where they get a major setback in their uh, final rank. So a question appears from one of these topics, and in the exam they start getting confused, or they are not very clear. So my attempt of taking these sessions is that you are absolutely clear. First, you know what are these high topics which has very high frequency of getting questions repeated. What kind of questions can you expect on these high topics? And the way I will teach you is I'll show you an actual exam question which has been asked in the examination, and then we will discuss the topic in detail, whatever that high topic may be, and eventually we'll discuss the answer. And as I am discussing the topic, I'll tell you exactly what questions have already been asked on that topic, so that you have a complete understanding. Now, you may be joining any app, any physical coaching institute, or you may be a dropper who is like, preparing on your own because you have covered your syllabus, or you may be even a fresher, just thinking of starting PG preparation or just started your PG preparations. These sessions are very critical for you, because if you are a fresher, it orients to you that what are these important topics and what are the questions which have been asked on this topic. Okay, so Dr. Sindhu, welcome to this session, and from Chennai. Great. So we'll start the session. Okay, and in each session I've started with half an hour, and as based on whatever feedback I get, whatever response I get, I will try to increase the length as we are moving more towards the examination. Sounds fine? And obviously I will just request all of you, to share these sessions, to ask your friends to come to these sessions, because eventually this will really help them in their preparation. So let's start with the first question of today. Okay, this question appeared in NEET PG 2022, and it's a biochemistry question. Okay, so this question talks about okay, there is some problem with my, let me see, my pen is not working, so I'll have to find a way to make it work. Just give me 1 minute. I've been conducting these sessions. I know I'm conducting this session after a very long time. Earlier I used to conduct a lot of MCQ sessions, both as a part of Unacademy, when I was a part of the Unacademy. I think now my pen should work. Okay, yes, it is working. So let's start with the first question of today. So I can see whatever chat you are going to put, whatever you are going to put, so that I can reply to it. So the first question is: a paint factory worker working since 20 years complains of joint pain, insomnia, fatigue, constipation, headache. And when you have examined, you have found him to have anemia. So he's having pallor. So which is the enzyme affected? Your options are uroporphyrinogen 3 synthase, uroporphyrinogen 1 synthase, ALA synthase, and ferrochelatase. So I'm waiting for answers. Just all the people can just put in their answers. Whosoever is live can put A, B, C, D, whatever the answers they feel is correct. Okay. So first, the question itself is very clear. We are talking about lead poisoning. Okay, and what kind of lead poisoning? Chronic lead poisoning. Okay, so this again is a very high topic. So I will, before even discussing this particular question, let me talk about lead poisoning first. Okay, so we know that metallic lead and all its salts are poisonous. This is again a very important concept which you have to remember. Not only metallic lead, but all the salts of metallic lead are poisonous. Another very frequently question which was asked earlier, now not in these days, are there are some very commonly used products which have lead in them. So the name was given and you had to identify that what is the lead component which was there. For example, they talk about sugar of lead, also called as Saturn lead. So what do you think is the component of sugar of lead or Saturn lead? So in sugar of lead or Saturn lead, we have got lead acetate. This was asked in the examination. Another very common lead product is what we called as safeda. So what is the lead salt which is present in safeda? So here remember it is lead carbonate. Okay, another very important is what we call as vermilion or sindoor, okay, which the ladies will put. So again, what is the lead component which is present here? So remember here it is lead. Yes, very good. Tetra oxide, excellent. So these three are very frequently asked, and this can be asked in your Viva examination also if you are going for your examination if you're still an undergraduate, and these has already been asked as MCQs in previous year examination. Another very important question on this point is, in terms of salt of lead is, which is the least toxic lead salt? And this is very important when we will see the management. I'll bring you back to the management, but what is the least toxic lead salt? And the correct answer will be lead sulfide. So this I will tell you what is the implication of this when we are talking about management. So least toxic lead sulfide. So what is the mechanism how these lead you know uh, uh, metallic salts actually lead to uh, formation of pallor and all the other chronic lead poisoning symptoms. So remember, this lead actually combines with the SH group of the enzymes. So enzymes are made up of amino acids, and there are some amino acids which will have SH group. Okay, so lead interacts with this SH group of amino acids. Understood? So once lead interacts with this SH group of amino acids, so there are two categories of enzymes. So it will inhibit a lot of enzymes, but primarily in heme synthesis, okay, and also in cytochrome synthesis. Okay, so also because of this you can also have hemolysis. Okay, now when we talk about heme synthesis, there is another question. Heme synthesis itself is a very high topic. Remember, I'll take a question on heme synthesis in one of the questions. But remember, in heme synthesis there are two enzymes which are specifically inhibited, very important. One is ALA dehydratase and second is ferrochelatase. Okay, now both these enzymes are inhibited. Okay, so there are some very important point about this I'm going to tell you, and you have to remember from exam point of view. First, obviously, what does ferrochelatase do? It will put the iron into the heme. Okay, in the heme synthesis iron is added on this step, and ALA dehydratase is the second step of heme synthesis where water is removed from ALA. Okay, so remember, it is not ALA synthase but it is ALA dehydratase. Is it clear? Very important when both these options are given, because in 1 year both the options were given and you had to choose one. So which will you choose between ALA dehydratase and ferrochelatase? Can anyone tell me? If both the options are given, that which of the following enzyme is inhibited maximally by lead, and both these options are given, which will you choose? So remember, ALA dehydratase. Okay, so lead salts inhibits ALA dehydratase more as compared to ferrochelatase. Is it clear? Both are inhibited, but ALA dehydratase is inhibited more as compared to ferrochelatase. So this was a controversial question. Many students keep asking about this. So is this point sorted out? So we have talked about what are the various salts of lead, and what is the mechanism of action which leads to the lead toxicity, which are the major enzymes which are involved, which are affected in lead poisoning. Now let's talk about, earlier there was a question on fatal dose. So fatal dose, two compounds have been asked about their fatal dose. So the two compounds are lead acetate and lead carbonate. Okay, so both these have been asked. These are very earlier pattern questions, but again, because we are covering it, so it is 20 gram and 40 gram is the fatal dose, and fatal period, more as a part of forensic question, fatal period will be 1 to 2 days. Okay, so again, these are PYQs which have already been asked. Okay, now let's look at, so there are two kinds of poisoning which is possible with lead poisoning. One is acute poisoning and one is chronic. So what are the various features of acute poisoning? Okay, so remember, number one will be astringent or metallic taste. So this is first. Second will be, you will have a dry or a sore throat. Increased thirst can also be complained by the patient. Okay, another very important thing is abdominal pain. GI symptoms will be very important. Also, you can have peripheral vascular collapse or peripheral circular collapse. Circulatory collapse can happen in, especially in children. A symptom is asked. In children, you will have cerebellar ataxia. Again, this is a question which have been asked in PYQ. Lead poisoning is a super important topic, and you won't believe that if you have covered this 5-7 minutes with me, there is no NEET PG paper, there is no INI-CT paper where you will not be able to answer one question. It is such an important topic, such a simple topic, such an important topic, and so many different types of questions have been asked. And this again is a very important thing which I want to tell you, that you may not have the same questions getting repeated. Okay, the probability of the same question being repeated is hardly 20%. But remember, the same topic being repeated is 80%. So you have to, once a topic becomes high topic, it is very important that you kind of learn the topic properly. Okay, so I was talking about cerebral ataxia, especially in children, and then non-specific symptoms like headache, weakness, insomnia, all those non-specific CNS symptom. Because all this inhibition in terms of you know uh, heme synthesis and all will take a lot of time to develop. Okay, so astringent taste, metallic taste, throat, increased thirst, sore throat, abdominal colicky pain, peripheral vascular collapse or circulatory collapse. Then you will have cerebral ataxia, especially in children, and finally non-specific symptoms. So is everybody clear about what are the symptoms which you are going to get in lead poisoning, acute lead poisoning? Any doubt till now? So let's now look at what are the symptoms which we are going to see in case of chronic lead poisoning. Okay, and you can remember it by a mnemonic called as NEW A B C D E. Okay, so all the symptoms, even when you are in a final year or in a second year and you have to write the symptoms of chronic lead poisoning, by this mnemonic you will be able to answer anything. So we'll take new at the last. First start with A. A stands for anemia. Okay, now remember, anemia is very it is the earliest and the most consistent, look at the words, most consistent and earliest finding in chronic lead poisoning patients. Okay, the most also can be most common sign seen in chronic lead poisoning, and it will be anemia. Okay, one very important, when we talk about B, you know, basophilic stifling will be seen. Another important thing with B is Bertonian lines. So what are Bertonian lines? Basically in the gum, you will have a purplish discoloration of these patients. So they will be having good oral hygiene, but still you will have purplish discoloration of these, of the gums, lining of the gums, which will be seen in these patients. So that is called as Bertonian lines. Let's talk about C, and remember, Bertonian lines are more common as compared to A. It's a very common finding if you see in these patients. Let's talk about C. So C starts with colicky pain. So all of these patients will complain of colicky pain. Another very important part with C you have to remember is constipation. Very few patients will have diarrhea. Mostly, chronic lead poisoning patients will have constipation. Clear? Let's talk about D. What does D stands for? So remember, D is for drop. So foot drop, wrist drop, very characteristic of your you know uh, chronic lead poisoning. Okay, foot drop or wrist drop, you know, is it. Let's talk about E. So E stands for eosinophilia. Okay, eosinophilia and also encephalopathy. Okay, a lot of CNS symptoms are seen. And what does F stand for? So we again talk about facial pallor separately. So these are, yeah. What does N stands for? N stands for nephropathy. Okay. Now remember, when I talk about nephropathy, it is a very late feature in cases of chronic lead poisoning. Again, a very important MCQ here. So in this simple thing, whatever I have talked to you, there are so many MCQs which have been already asked. Now, how do we do the diagnosis? How do we diagnose? What test we do? So there are certain blood tests, some urine test, some x-rays also you can do. So let's talk about some blood test. So what will you find in blood? So obviously eosinophilia, basophilic stippling, this will be, you will find. Also you will find increase in level of lead and increase in the level of ALA. Okay, specifically more than 25 milligram per 100 ml ALA, because ALA dehydratase. ALA, remember one enzyme is ALAD, which is deficient. So because this enzyme is deficient, the level of ALA will increase. Let's talk about urine. So all the heme synthesis precursors will increase. So you will have increase in coproporphyrin and also increase in ALA in the urine also. Okay. Also there will be increase in lead in the urine. So all these things will be increased in urine. If you do an X-ray, especially in acute poisoning, when you suspect the child has eaten something, you can find the it as a what you call as an opaque finding. Okay, and if chronic lead poisoning is there, especially in the children, then you can have a line at the metaphysis of long bones. Okay, so line at metaphysis of long bones. Okay, so this is how you diagnose. Any doubt? Once you have diagnosed a chronic lead poisoning, how do you manage this? So what will be the treatment for this patient? So if it is acute case, gastric lavage. Okay, and second very important thing is 1% sodium or magnesium sulfate. Why? Because the lead sulfate, remember, it is one of the it is one of the least toxic. Sulfates and sulfides are least toxic. So we use this. Next, if we know, if it is chronic, we can go for chelation. There are two agents which we recommend for chelation. One is British anti-leukocyte and the second is DMSA. Okay, so both has been asked in the what is the most effective antidote in cases of acute poisoning. So calcium disodium varsinate. So this is the most effective antidote. Again, this has been asked as a question. Calcium disodium worsenate is the most, and obviously based on the symptom and severity, if it is especially in acute cases, peritoneal dialysis or hemodialysis with symptomatic treatment you have to do. So this is all about lead poisoning. Is everybody clear about lead poisoning? Any doubt? I'm just looking at the chat. If any doubt is there, just let me know. Any doubt? Good. So this completes our entire discussion on lead poisoning. Let's move to the, so when we look at this question, finally, so we know this is a case of chronic lead poisoning, and the enzyme which is inhibited is ferrochelatase. Remember, it is not ALA synthase, it is ALA dehydratase. Okay, right? So again, once again, at the cost of a repetition, I'm telling you whatever questions I'm going to discuss in these sessions, which I'm going to take every day in the evening, Monday to Friday, all of these are high yield topics, which means, if you go through around 700-800 of such topics, easily 60 to 70% of the questions will come from these topics, right? So let's look at the next question. The next question is, drug of choice in paracetamol poisoning is, okay? So antidotes, all these, poisoning questions are again becomes very, very important, okay? So what will be the answer? Just write in the comment what will be the answer for this question. Acetoaminophene poisoning, what will be the answer? Anyone? So let's look at some of the most important poisonings and what will be their antidotes. So I'll just list, okay? So organophosphate poisoning, anyone? What will be the drug of choice for organophosphate poisoning? All they say as carbamate poisoning. Also sometimes they will talk about early mushroom poisoning. What will be the drug of choice? Anyone? So remember, it will be atropine. Okay. So I'm going to talk about 7, 8, or 10 most important, poisonings and what are their antidotes. The second they will keep talking about is atropine or belladonna poisoning. What should be the antidote for this? Also, sometimes they talk about dhatura poisoning. Very frequently, they will ask what is the antidote for this. So remember, it is physostigmine. Okay. Let's talk about the third, very important, very frequently they will ask, acetaminophen, also called as PCM. So what is the specific antidote for it? Acetylcysteine, N-acetyl, okay, N-acetylcysteine. Okay. Also, you can talk about cysteamine. But remember, N-acetylcysteine is safer as compared to cysteamine. So when both the options are given, you will always go for N-acetylcysteine. Let's talk about the next important toxins. So they will talk about benzodiazepine. What is the specific antidote for benzodiazepine? So remember, it is flumazenil. Okay. Next, they will talk about opioid toxicity. So naloxone. Okay. Naloxone will be there. Next, very frequently they will talk about iron poisoning. And in iron poisoning, they will talk about acute iron poisoning and chronic iron overdose or poisoning. So what should be the answer for acute iron poisoning? Anyone? So it is deciferoxamine. Okay. And what about chronic? It is defepirone. So again, iron poisoning, very frequently they will ask. They will also talk about cyanide poisoning. They have asked multiple times. So what is the specific antidote for cyanide poisoning? So it is amyl nitrate. So these are, there are hundreds, but I am listing you the most important. Again, they will talk about tricyclic antidepressants, okay, like amitriptyline, clomifenirine, or imipramine. So remember, IV sodium bicarbonate. Okay, this has been asked, I think, last year only. And lastly, if you talk about beta blockers, glucagon. Okay, so these are the most important, drugs or antidotes for various poisoning. None of these you should forget. Okay, each one of these have been asked multiple times. I think this is all which have been very frequently asked, so you should remember it as a part of high yield topic. Okay, so poisoning and what is their specific antidote. Okay, let's move to the next question. So okay, so let's first discuss this. So the correct answer, paracetamol poisoning, will be N-acetylcysteine. Okay, right. Let's move to the next question. And the camp regulator in lac operon is known for which of the following function? So this appeared again in NEET PG 2022, and the options are positive regulator, negative regulator, constitutive expression, and both PNC. So if you are live, just try to answer this question. So this question again is a very important high yield topic. The camp regulator in lac operon is known for which of the following function? And your options are positive regulator, negative regulator, constitutive expression, or both B and C. Anyone wants to attempt this question? Okay. So before I actually take you to the question, let me quickly, talk about operon concept. Okay, so this is the structure of an lac operon gene. Okay, and it is an example of a polycistronic gene. What is a polycistronic gene? Okay, can anyone write in the comment what is a polycistronic gene? So remember, these are seen in prokaryotes, which means multiple genes, example in this case 3 genes, is under a same promoter. So once the transcription happens, all these 3 genes will be, transcribed. Understood? As opposed to something like a monocistronic gene, where each gene will have its own promoter sequence, and this is a characteristic of eukaryote. So again, polycistronic gene, monocistronic gene, seen in prokaryotes, eukaryote. This is a very important question. Is everybody clear? What is a polycistronic gene? Okay. Now, having understood this, first let's understand why operon concept is needed. Okay. So let's say there is a bacteria. Okay. So bacteria can use both glucose as well as lactose as a source of energy. Okay. Now, suppose this lac operon. Okay, this is to be on only when the bacteria wants to use lactose as a source of energy. So let's imagine multiple situations. Let's say in a medium glucose is present, lactose is absent. Okay, or let's say glucose is absent, lactose is present. Let's say both are present and both are absent. So what should happen in each of these cases? First, let's understand conceptually. Let's say glucose and lactose both are there in the medium. So what should you want the bacteria to do? Do you want the bacteria to use glucose or lactose? So because glucose is a more, efficient source of energy, so you want the bacteria to use glucose as a source of energy. So this lac operon should be suppressed, not completely shut off, because some amount of lactose is there, but it should be suppressed or moving very slowly. So all these genes should be transcribed slowly. Let's look at this situation, the situation, second situation. Okay, in this there is no glucose but lactose is there. So this is then when you want, this lac operon to be switched on and completely transcribing at the fastest rate possible, because these genes will produce enzymes which will help in digestion of lactose, and the bacteria will be able to yeah. Okay, if both are present, then again it will be suppressed, because you want the bacteria to use glucose, and if both are not there, then again it should be off. Is this clear? So first we have understood that why this lac operon is required. Okay, based on what is the uh, energy source available in the medium, the bacteria should be able to switch on and off these genes transcription. So let's look at what happens. Normally the lac I gene is always functional, and lac I gene, because it is always functional, this is also called as the constitutive gene or housekeeping genes. Okay, in each genome there are some genes which are always transcribing. So these are called as constitutive genes or housekeeping genes. So in this case, lac I is a constitutional gene. So what it does, it will keep producing inhibitors, and what will this inhibitor do? It will go and bind to the promoter sequence. So now, you know, here the the polymerase cannot, RNA polymerase cannot attach, and so these genes will be switched off. So normally lac I is creating these inhibitors, okay, and these inhibitors will go and attach to the promoter sequence, and because the promoter sequence is, concealed by these inhibitors, so these genes will never be transcribed. Is it clear? Is this point clear? Now imagine if lactose comes in the medium. So this lactose will actually go and attach here and disrupt this tetramer, and once that tetramer is disrupted, the promoter sequence becomes free, and now here, RNA polymerase can come and bind. And what will happen when RNA polymerase will bind? You know, the transcription of all these genes will happen. Lac Z will produce beta galactosidase, which will help in breakdown of lactose. Lac Y will, create permease, which will help in entry of lactose into the bacteria. And lac A is galactosidase, which will again prevent entry of lactose. So what is happening? Whenever lactose is there, these genes can be transcribed, and it will help in digestion or breakdown of lactose to produce energy. Is it clear? Right? Lac operon. Now, this is first level concept. The second level is basically what happens if lactose and glucose both are there. So remember one important concept. Whenever glucose level falls down, CAMP level increases. Okay. So whenever glucose level falls down, cyclic AMP level increases, and this cyclic AMP can attach with catabolite activator protein and get attached here. Okay. Now this act as a positive regulator, which means if this dimer is attached here, the RNA polymerase can easily find promoter sequence, and these genes will be transcribed at a very high rate. Okay. Imagine if the CAMP level is low. Okay, if the CAMP level is low, so this dimer will not attach here, and the you know and the transcription will happen at very low rate. But imagine when the glucose level is low, CAMP level is high, okay, and there is lactose in the media, because if lactose is not there, there will be a inhibitor which will be attaching here. So anyways polymerase cannot attach. Okay, is it clear? So this is cyclic AMP level. If it is increases, it will attach with this catabolite activated protein, go and attach itself to the CRE segment, and once this is attached to the CRE segment, it acts as a positive regulator, leading to the increased transcription of all these three genes. Okay, so this is very important. And if glucose is present, what is going to happen? If glucose is present, the cyclic AMP level will be very low, so this will not be increasing the efficiency. Okay, so this is what we achieve with the lac operon. Okay, so again I am telling you, so whenever, let's talk about glucose and lactose level. Okay, if in the medium only glucose is there, lactose is not there, then it is off. Why? Because the inhibitors will be attached on the promoter segment. Let's say if glucose is not there and lactose is there, then what will happen? First of all, these genes will be switched on. Also, because of the CAMP dimer, which is a positive regulator, there will be very increased speed of transcription. Okay, let's say reverse condition, when you have both present, then again it will be on, but it will transcribe at a very slow rate, because this regulator will not be getting, positive regulator will not get attached, and if both are not there, then it will be off. So this itself forms a very important question. What will happen to the lac operon if both is not there, if both are there, if glucose is they not there but lactose is there, or when glucose is there, lactose is not there? So we have seen that CAMP regulator in this case acts as a positive regulator, because when this is there, there is an increased rate of transcription. Clear? So this again, lac operon, very very important topic, especially for FMG. Almost every year they will give one question on lac operon. Okay, so this is uh, about the lac operon concept. Is everybody clear about lac operon concept? Okay, so this brings us to the end of today's session. I have taken it after a very very long time, but I intend to continue these sessions, and hope you find these sessions important. Whatever I'm going to discuss in these topics, I mean, easily if you follow these sessions for next 6-8 months till the time of your examination, you can see that almost 60-70% of the questions will come from these sessions. Ultimately everything what you're going to read will boil down to these questions only, these concepts only. And as you might have realized, that I'm not only discussing the question and the concept, but I'm telling you all the questions which have been asked on those topics. Okay, so hope to see you tomorrow again at 5:30 or 6. I will take these sessions in the evening, and these sessions will be there for 24 hours, and after that it will be deleted. So if you are not attending live, at least try to see the recorded version of it within 24 hours, because after 24 hours it will be deleted. Okay, so thank you so much. Just give me a heads up who all is present till this time, who would have completed your session. Okay, great. Just you know put your names in the chat. I'm just trying to read whosoever is present there. Okay, so anyways, thank you so much for attending this session. Again, we will try and connect tomorrow with another 3-4 very high topics and actual exam questions. Thank you so much. Take care.